Okay, Assalamualaikum warahmatullahi wabarakatuh. Good afternoon again. I think this is the last part of the Neuroophthalmology lecture series. I will just continue on the visual field interpretation just now. Okay, all right. So how to localize the lesion? Okay, so if you find monocular visual field defects, so it indicates the lesion is anterior to the optic chiasm. The bitemporal defect, it actually tells you that the lesion is actually in the chiasma. Binocular homonymous hemianopia or bilateral homonymous hemianopia. It means the lesion is either on this is the left homonymous hemianopia, this is the right homonymous hemianopia. So the lesion must be contralateral to the part where the patient cannot see. Okay, and if the patient only cannot see a little bit, a quadrant of the field, it's called quadrant bilateral quadrantanopia. Okay, right quadrantanopia or left quadrant, superior quadrantanopia or inferior quadrantanopia. Right, so this will make you understand a little bit further, but I bet you have seen this before. Okay, so this is your nasal retina and this is your temporal field, temporal visual field. This is your temporal retina corresponding to the nasal visual field. Okay, so this is a very important picture, always come in the exam. If it doesn't come this year, it will come next year, but it always come. Okay, so this is if the defect is at the optic nerve, one eye is gone. Okay, monocular visual loss. If the defect is at the center of the chiasma, then the visual field is a bitemporal hemianopia. If the defect is somewhere small, just on the side of the chiasma, it can be like this. But probably it's a bit advanced for you. At your level, at medical student level, you must know up to here. Okay, the lesion is here at the optic tract. This is a right homonymous hemianopia. Okay, right homonymous hemianopia, it refers to the part where the patient cannot see, and the lesion is always contralateral to the where patient cannot see. So right homonymous hemianopia indicates left CVA. One of the main causes is stroke. CVA can be anything: multiple sclerosis, a stroke, a tumor, aneurysm, blah blah blah. Okay, or hematoma. Okay, traumatic hematoma, whatever, compressing this area. All right. And this is the right superior quadrantanopia. This one is the inferior right quadrantanopia. Bilateral inferior right quadrantanopia. Okay, this one is a right homonymous hemianopia with macular sparing. Okay, right superior quadrantanopia is this one is this one is the temporal lesion at the temporal side of the brain, while the inferior quadrantanopia is at the parietal part of the brain, and the right homonymous hemianopia with macular sparing is at somewhere at the optic radiation. But remember, at your level, usually we will ask up to here. Okay, so you must know how to label all this. Okay, don't get confused. You must know how to label all this. All right, isolated. I think these are just repetition. Okay, repetition. Make you understand more. All right. Again, there's a pituitary adenoma here. There's a tumor here. It causes bitemporal hemianopia. Okay, there's an optic tract lesion here. So where does patient cannot see? Must be on the opposite side. Okay, so left homonymous hemianopia. Incongruous, congruous, it doesn't matter. Just know where the lesion is. Okay. Alright, these are a bit too advanced for you. Probably just ignore this. Okay, I think I better stop here because the next lecture is like a totally different subsection of this. Alright, see you in the next lecture. Bye.